You're hit. You're bleeding, man.
I ain't got time to bleed.
Oh. Okay.
Hey, everybody. It is the Austin Travis County EMS System Office of the Chief Medical Officer official podcast. I'm your host, Dr. J.R. Pickett, and today I have a very special guest with me, Dr. Joseph Martin. He is an EMS fellow in San Antonio, fully boarded in family practice, emergency medicine, and addiction medicine, and now completing his EMS fellowship because apparently he just likes having all of the specialties. Joe and I were talking at a recent conference and said that we should get together and do this podcast on first responder mental health. And so here, I'm so glad to be able to sit down with him today. Joe, thank you for joining me today and coming to talk with me about this topic.
Absolutely. Thank you for having me. It's a genuine pleasure to be able to speak with you and kind of talk about this topic. It's something that's particularly near and dear to me, one, because as you know, I work a lot with first responders in San Antonio, fire and EMS and PD. But I think it's a topic that doesn't get enough attention and definitely deserves a little bit more light to be shown upon it so we can talk about it and discuss it and learn about it.
I think it is an important topic because, one, I think that we as first responders tend to shy away from help. We are the helpers, and we tend to think that no, I can handle this because I handle a lot of other gnarly stuff in people's lives. And I think that we forget sometimes that when it comes to mental health, when it comes to addiction, there's not a single one of us that isn't touched by addiction in some way, that hasn't struggled with it, or currently struggling with it, or in recovery, or we have a loved one that we've lost to addiction, or that is currently struggling with it, and so many of them are struggling silently, and we don't know. And so having this come out to the forefront, I think, is such a healthy thing for us, because it helps us to realize that we're not alone.
Absolutely. And I don't think there was ever a time period that's been more relevant than because of COVID. I think if there was ever a time period in the history of first responders as an organization and a profession that have been asked to do more with less, and especially with being provided less opportunities for help, less opportunity for downtime, less opportunity with their family, overtime is increasingly becoming a problem. But I couldn't agree with you more. I think this is something that we really we need to focus on to make sure that the opportunity to be a first responder and actually have a good family life and have a succinct and sustainable career is a continued thing for the future. Because at this point, I think there's a lot of folks who are struggling enough at this point that we may be kind of getting ready to step into a large crisis where we can't staff our ambulances and our fire trucks, and we can't get police officers to patrol the streets.
And why do you think this community of first responders is so at risk? You talked a little bit here about just the strains of staffing, and of course we're in a national, actually international shortage of EMS providers. Why is this population so at risk?
Well, and to be honest with you, I'll take a step back even further. I think we've all been intimately aware of the fact that there's shortages of workers everywhere. It's hard to go to the restaurant and find all of the tables having a waiter or a waitress. Lines waiting at movie theaters, lines waiting at checkouts and grocery stores and grocery markets are longer. Everybody's just burned out. I think that's true for our folks that are working for fire, EMS, and PD, but also just a regular Joe Schmo rocking down the street. I think everybody's burned out. I think COVID strained societal and cultural and physical relationships tremendously, and I think the recovery process is going to take years, if not even maybe a decade, to really truly rebound and recover and feel quote unquote normal, if we ever get back to another normal or establish a new normal. But I think specific to our first responder folks, they have been arguably the single portion of the population that really hasn't had an opportunity to really reflect and kind of come back or try to establish a new normal. They're still essentially being worked as though we're in the middle of a pandemic, and because in a lot of ways we functionally still are, even though things are better than they were, say, March of 2021. But they're still not back to normal by any stretch of the imagination. And I think the hardest part for first responders is they haven't had a chance to catch their breath. but I think that's one of the things that we need to do, as you and I working in medical direction and the administrative role is trying to advocate for these folks and trying to give them a voice and elevate their needs and making sure that it is recognized that we are continuing to ask them to do more for less and that they need a break too, lest we end up with a completely dysfunctional workforce, understandably so.
Why do you think there's that culture within EMS and fire? Why are we so resistant to getting help, to admitting that we need that's a normal part of our sustainment?
So I was kind of quite literally, as I was drinking my coffee this morning, I was thinking about that, and I think one of the things that we have some carryover with our first responder colleagues. Even though I definitely defer to them and respect that they take this to the next level, when you decide to work in the emergency department, you kind of decide to be that crazy person that runs towards chaos, not from it, that runs towards fire, not from it. And they take that to an additional level where they don't have the protection of the emergency department. They don't have the resources of a hospital. And they often don't have the backup that we have as emergency physicians in the trauma bay or in the resus bay. And they do a lot of the things that we do with a hell of a lot less support. And that's been their culture. That's been their nature. That's what they signed up for. They understood that. But there's kind of always been this unspoken societal understanding that there's this unwritten contract that like they get the support and they get the respect and they get the love and care that they need from their communities. And I think especially because right now so many people are genuinely short on love and short on patience just because everybody's so damn stressed. It's very difficult for folks to remember that, you know, being a police officer is a hard job. Being a firefighter is a hard job. Being on an ambulance is a hard job. Bouncing down the road at 80 miles an hour in the back of a box trying to start an IV is not an easy job. And I think everybody's gotten so stressed out that the frustration levels are at an all-time high. Not even talking about the economy and inflation, the things going on in Ukraine. I mean, everybody's stressed to the max. And the single, in my opinion, obviously I'm biased, but I think the single patient population, the single population of our workforce that hasn't had a chance to get their breath, I know I've said this before, has been our fire, EMS, and PD and first responders. But I think that culture comes from the fact that they historically have always been the ones to be yes men and yes women and run towards the crazy and run towards the chaos and figure out a way to make it work. Their entire job is to bring order to chaos. And they do it very well. They've done it very well historically for over 100 years. And this I think is really the first time that they haven't had a true opportunity to kind of reflect on all the things that they've dealt with over the last 2.5, 3 years of the pandemic.
Yeah, I think there's a particular subset here within this population as well, which is leadership, which is the chiefs, the commanders, the district chiefs. You know, the ones who are that rock watching out for their medics. And it's easy to say, you know, for the line medic, you know, here you've got all these peers, you have peers to look at, to talk to, and the further up in that chain that you go, the fewer people you have to talk to, the fewer people that there are that at your same level where you feel like you're in a safe place that you can share some of these concerns.
Absolutely. I think relatability is everything. And I think that's kind of the big challenge is that everybody's stressed, whether they work, quote unquote, just a desk job or whether they are working on the box, everybody's stressed. And everybody wants to get back to their family. Everybody's hoping to go home to their family. And I think it becomes very difficult trying to find that window of opportunity to reflect with the people that you respect and your peers and your superiors, and finding that opportunity to say, you know, hey, I think I might need some help. When you recognize around you that everybody is stressed to the max and they don't have help themselves. And then you incorporate a culture that's very self-sufficient, very self-sustaining, and very much tries to elevate themselves, quite literally elevate themselves above needing help. And it's this perfect recipe for disaster.
Yeah, I find that burnout sometimes or emotional stress, burnout, whatever term you want to put, it manifests itself in errors. And sometimes it comes out because a medic has made a medical error, whether it is a drug dosing error or a cognitive error or something like that. And so it comes to our attention as medical directors. And as we are looking into the contributory factors, and we see that this medic's got stuff going on, and we're probably like well beyond the point that they should have asked for help or should have entered that mental health care system, especially by the time they're willing to say, yeah, I think I need to talk to somebody. They've been struggling for a while. And by the time somebody notices and says, hey, is everything okay with you? And I think that we're well beyond the point we should have said something. How do we identify this sooner? How do we find a way to find that sooner where we can intervene before it becomes something that's really affecting somebody's work, before it's affecting their work quality and safety, where they're potentially putting patients at risk, potentially manifesting high risk behaviors for themselves? How do we identify them and get them onto that path before they reach that point and they themselves are at serious risk?
How do we develop a proactive and preventative system rather than a reactive system? I think one of the big challenges is that we have to risk stratify the things that our medics and that our firefighters and our police officers are exposed to, and figure out what things are particularly damning, what things are particularly difficult to go to sleep at night after you experience, and then provide resources for the folks that are experiencing those events. Before we started this podcast, we were briefly talking about ACE scores. ACE scores, for anybody out there who aren't familiar, it stands for Adverse Childhood Experience Index. It was a wonderful social and behavioral study that came out from Kaiser Permanente in the late 90s, early 2000s by a internist, I believe, by the name of Vincent Folletti. But he came up with this scoring system. I believe it was about 10 questions that essentially evaluated how adverse childhood experiences subsequently manifested into real world, real health outcomes. So he was able to risk stratify specific events within a childhood, within a child's development or within childhood experience that subsequently manifested into things like high blood pressure, things like obesity, premature death, heart attack and stroke, smoking, IV drug use. It was actually impressively illuminating to the fact that we really could track that when you experienced more stress as a child, specifically in this study, you were more likely to engage in high risk behavior or engage in things that ultimately had a detriment to your health. And I think we can study and identify these things in our first responder population successfully as well. And I think we can recreate the ACE scores for first responders so that we can identify which of those significant events that folks experience on their shifts that subsequently can manifest themselves into at-risk behavior or high-risk behavior, or put them at higher risk for suicide, homicide, or premature death. We know a lot about this patient population in the sense that a lot of this is sleep deprivation, but we also can absolutely respect, as healthcare professionals, that a lot of this is also what we take home from our shifts and what we take home from our patients and from the people that we interact with in the street. You know just as well as I do, unfortunately, this can be a frustratingly thankless job sometimes. And oftentimes, especially here lately with the increase in methamphetamine use, the increase in heroin and opiate use, and other illicit substances, that a lot of patients on the streets are getting angrier and getting more unruly and getting more violent and more dangerous, not less so. And, anybody would be foolish to not think that this is also adding to the problem. I do have a study that was published in the Journal of Sleep Research in 2019. It was a cross-sectional study on 6,300 firefighters administering the Maslow burnout inventory. Essentially, that like the more sleep deprivation you had, the higher risk you were for badness of all kinds.
Yeah, I think it's easy to recognize some of those really bad calls. So you go to the crash where a child dies, or you have a young person that's taken very suddenly from this world, or you have a married couple. They've been together for decades, and one of them dies or has a horrible outcome. They'll never be the same, and you see the effect of that on their loved ones. I think it's very easy to recognize those as things that have an impact. But I think when I hear from medics who quit this job, they are citing this, well, I can't believe we're going to this call, and I'm waking up in the middle of the night for a priority 4 unknown because some drive-by hero with a cell phone saw someone sleeping by the side of the road and called us, and here I am going to check on somebody who's just sleeping in their normal environment. And that feeling of like, what am I doing here? Why is this? Why am I doing this job? I was here to save lives. Is not what I'm doing. And I feel like that's a lot of this burnout that people feel like when they get up, especially in the middle of the night. You mentioned sleep deprivation. We interrupt their sleep cycle to go to these calls, and what they feel is not consistent with their normal job. When it really is a large part of their normal job.
No, absolutely. And I think it's very challenging to reconcile the fact that if we're lucky, about 20% of our job is the fast-paced, sexy, life-saving stuff that we signed up for. And a lot of the time, sometimes 80 to 90% of the time, our job is not that. Either our job in the emergency department or our job in the streets. And I think there's value to both. I think a lot of it has to do with being honest with our fire, EMS, and PD folks whenever we're explaining exactly what the job entails. I think it's very easy to advertise the sexy Arnold Schwarzenegger life-saving stuff. But it's a lot harder to reconcile what the day-to-day is going to be like. But I think there's value in both things. Specifically with the late night calls, with the priority 4 activation stuff, I think there's opportunities for growing the system so that happens a little bit less often. We're seeing that get better as far as with clinical dispatchers, as far as advancing technology and being able to do field triage via remote, like FaceTime type applications that allow a clinically trained dispatcher to be able to say, okay, this is somebody who is clearly sleeping versus this is actually someone who may be in cardiac arrest. So I think we're doing more to decrease the workload on that regard, on fire and EMS specifically. But of course, we could always do more. But those frustrations will always exist. And I think the counterbalance to that, quite honestly, is doing everything that we can to create an environment for our medics that makes those interactions that much less taxing. Part of that is helping them with sleep deprivation, with helping them to get more sleep, helping them to have less interrupted time. And quite honestly, time to reflect on all of the things that they see, good, bad, ugly, and everything in between.
Now, what are some of the indicators that you see, the early indicators of burnout? I mean, obviously, somebody hauls off and slaps a patient or something like that, then it's whoa, time out. Okay, we got to get you to talk to somebody. But there's got to be indicators before that. What are some of those? Absolutely,
and I'm glad that you asked that, because I think that's a topic that also doesn't get enough attention, specifically within this realm. The things that demonstrate, or the potential signs of early burnout, are the same as in the general population. Social withdrawal, folks that are turning to substances for reflection and in their downtime more often than they have historically. Their social and support systems recognizing that they're not acting like themselves. Occasionally, it can manifest itself as violence. I definitely don't ever mean to, insinuate that our fire and EMS folks can be violent people, but when pushed to the limits, anybody can be a violent person, and goodness knows this particular population can be pushed and stretched to limits far beyond that of the average person. But violent outbursts absolutely can happen. I think things that tend to be a lot more subtle and a lot more common are that social withdrawal. And honestly, it's when your social and support system that you naturally have start to worry and start to recognize that you're not acting the same. I think very keen shift supervisors and battalion chiefs and folks that are hands-on administrators can absolutely notice when there's been a change in their medics and in their firefighters and their PD. But I think a lot of it has to do with, quite honestly, creating that culture of paying attention. I work with the general population in addiction medicine and mental health a couple days a week, and I think one of the things I try to stress to them is that burnout in a lot of ways is an absence of belonging and an absence of community. Our professions, specifically fire, EMS, and PD and first responders, are very unique, and they're very resolute and very capable of dealing with, quite honestly, just a lot of bad shit. And they're capable of doing that purely because they have an innate community built in with what they do, a brotherhood and a sisterhood that has that peer support, that belonging, that sense of being part of something bigger than yourself. That's hugely protective. We've demonstrated that over and over and over again with studies in the general population, that the stronger the connection you have to your faith, regardless of what it is, the stronger connection you have to your family, the stronger connection you have to your own personal identity, the more robust and the more defended you are against burnout, depression, anxiety, and substance abuse, inappropriate substance use. But whenever those things start to slip away, whenever you start to have an absence of self, an absence of belonging in that community, and that brotherhood, that sisterhood, that greater belonging in something bigger than yourself, that's when you become at risk. That's when things really start to manifest themselves. And that's when you have keen people that are paying attention and that love you, that start to reach out and say, hey, something's off. You're not the normal John I'm used to, like, what's going on? And those need to be the things that we have to really pay attention to normalizing conversation about. I think, again, when you talk about protective mechanisms built into the first responder profession and career, the vast majority of our folks have partners. And your partner, 99 times out of 100, is going to notice, sometimes even before your wife or your husband, which is a huge thing to say out loud. But I think that's the thing that we really have to pay attention to, is we have to normalize a culture of partners reaching out that say, hey, I'm not trying to rat on you. I'm not trying to, I'm not trying to take money out of your pocket, but I am concerned because something's off. And I think there can be a way for that to be therapeutic without being punitive, without putting people's livelihood and their financial security at risk. And I think that's the culture we have to create.
How do you start that conversation with someone? So you noticed a change in them, and I think you touched on it. You don't want them to lock down. And a lot of times you ask them, "Hey, man, you good?" Like, "Yeah, I'm good." And that's the answer. Rarely does somebody say, if you just ask them, "Oh, is everything okay?" Like, rarely they say, "No, I'm really not okay." Or if they do, that's their one step from pulling the trigger on their 9mm in their mouth. How do you start that conversation early when approaching somebody, some opening up, because it is such a tough thing to admit?
I think that is the $1 million question, to be honest with you. I think one of the big challenges is that it's still being studied, but we have demonstrated and seen, and I don't think there's anybody who's paying attention who would argue differently, that because of the transition of culture with social media, compounded with COVID, compounded with social isolation, and compounded with added stress of everything that came with the current situation with the financial situation in the world and the pandemic, I don't think there's anybody that would argue that we're a less close society. I was talking with one of my patients the other day. When communities themselves were close enough that you knew your neighbors, it was a lot less likely that you would see somebody doing something shady at your neighbor's house and not call the cops and say something, or call your neighbor and say something. When you know your community, when you have that connection, when you have that, when you can, reconcile their identity and who they are, it's a lot easier to ignore things. It also subsequently becomes a lot easier to pick up on things. not to get overly, touchy feely and philosophical on you, but I think that's the big challenge, is that we have to figure out a way to reconnect as a society. The last holdout, arguably, was the brotherhood and sisterhood of first responders, because they went through so much stuff together. And we've now reached the point where, even going through that stuff together, we still have folks that are struggling to connect with partners that are going through terrible things side by side, hand in hand, because it's gotten to the point where it's just so damn terrible. I know not to make this about me, but I pronounced 8 people dead in 7 hours on November 4th of 2020 during COVID. Just me, myself, one single resident physician at a level 1 trauma center in El Paso, Texas. I have no doubt in my mind there are first responders that experienced that exact same thing, one after another, on repeat. And you can't not experience those things and not have a reaction or have a negative outcome. You just can't. You have to have that communication built in, that community built in, that support system built in. We have to find a way to rekindle that, recreate that, and as silly as that sounds, make people comfortable talking to each other again.
The other day, I saw this on one of our Facebook pages, and one of our medics was talking about how, like, everybody sort of vents about job, etc. And they said, well, who doesn't ever say this? Like, we joke about what a terrible job, or how tough it is. And they were like, who doesn't say that? Firefighters. They don't say that. They don't say, like, oh no, I wouldn't go into firefighting as a job. And I reflected on that a bit. I think first of all, some of the research that you've talked about has really been helpful in limiting the fact that they're struggling too. But I think there is that sort of sense of identity and sense of community that's very strong within the fire service. You're working in a group of at least 3 or 4 folks on your engine. Maybe you've got 8 at your station on your shift that and so you have that sense of community within that small group, and that sort of sense of, I don't say elitism, that's a terrible word. Well, it has a negative context, but that sort of like, hey, we're special, we're elite, and that helps with some of that, like you were saying, that resilience to enduring trauma, enduring frustration, and the like.
Absolutely. I think what you're touching on is camaraderie. I think that camaraderie historically has been relatively unique to first responders and veterans. And I think that's one of the challenges of why we see veterans struggle so much after they get out of the military. Obviously, to anybody who's in the military and who's struggling, I absolutely respect that. But I think there's a reason that we see that the degree of struggle and the public aspect of the struggle, and unfortunately the end manifestation of suicide, becomes so much more common for veterans once they're out of the military, because they lose that camaraderie. They lose that community. They lose that sense of duty, and that, quite honestly, the regularity of things. When you have a schedule, when there's something that, we've all had those days where we wake up and we're like, I do not want to go to work. I don't want to go do this thing. I'm absolutely exhausted, but we get up and we go do it. And then occasionally we're lucky, and at the end of it all, we're like, I'm really glad I got up. Today was a good day. And some days it's not, but you still have that opportunity to have that sense of duty that pulls you out of bed and that pulls you into something that's bigger than yourself, and gives you that opportunity to be exposed to your support system and that camaraderie and that brotherhood and that sisterhood. And that's protective. Not to digress, but I think an important tangent is, like, whenever we're for folks who are successfully in recovery from substance abuse or mental health problems, they do better when they're in peer support groups with folks who understand what they're going through. That is a basic tenet of all successful recovery programs, is that you have group therapy sessions and you have peer recovery support specialists that are there to talk with the folks that are struggling acutely in the moment when they're struggling. It's that protective mechanism of having that brotherhood, sisterhood, that group community mentality. And I think it's undeniable, and it's demonstrated years and years over and over again with research, that the more sense of belonging that you have to something, the less likely you are going to make, quite honestly, to engage in high risk behavior and make poor decisions, and the less likely you're going to suffer from depression, anxiety, and the more motivation you're going to have to continue to do quote unquote the right thing. And I think fire and EMS and PD are so specifically and uniquely situated to have that camaraderie and that brotherhood. So it makes it that much more dramatic whenever we have a firefighter, EMS folk, or PD that have a bad outcome or they engage in substance use. And it demonstrates kind of how far they've gotten in their isolation and how much of a better job we've got to do of pulling them out of it.
I'm glad you touched on that. So how do we help create that community? How do we help bind people together that way?
I think the resiliency factor comes hand in hand with community, which I know I've said a million times at this point, but also trust. I think, community is synonymous with trust. And I think you have to have that trust. You have to understand and know your partners, know your department, know your chiefs, know your medical director. I think a lot of it is very much an art, in that you want to create a cohesiveness within your department that facilitates good, close relationships that are organic, that aren't forced. No one likes mandatory fun time. It doesn't happen. I think it's a gigantic slap in the face, the mandatory wellness that gets thrust onto residents and fellows of like, all right, guys, this is a required thing. You have to have time in your schedule to have fun. So go and do this thing and have fun. Like that never works. It doesn't work. So you have to have this, and there is an art and a nuance to it of creating a department that's cohesive, where you actually have people that like each other enough that they want to spend time with each other outside of work. But when you can create that warm, fuzzy community, for lack of a better description, within your department, I think if we could figure out a way to quantify that, we would show overwhelmingly the more cohesive and the more connected inside and outside of work your department is, the less burnout your department has, the less bad outcomes your department has, and quite frankly, the more longevity your department has as far as personnel and employees.
I also read that PTSD is the realization that you will never be this awesome again.
And honestly, joking aside, there's a lot of truth to that. What do you do as a sentient being after you have the realization that you've peaked in a way? Do you find another peak? Do you create another peak? Are you comfortable with the realization that you have manifested a goal and now you have to start climbing back up a new mountain? I mean, it can be overwhelming. And I think that, I really do. I think that's the thing about community, is that we all naturally have high highs. We all naturally have low lows. But when you're in a good community, a good loving community, and have a good loving support system, ideally the group collectively is not experiencing a low together. There's always someone who's doing well who can lift you back up. And I think COVID was exactly the smack in the nuts that we all had of like, God, we're all down together. There's nobody to lift us up now. We kind of got to lift each other up or quit. And a lot of people just quit.
Conflicted feelings about when I see this. Like, hey, we're heroes. Nobody acknowledges that we're heroes. And I'm like, yes, okay, get a pat on the back. You're very special. And then at the same time, it's folks trying to define that community that they're part of, and that acknowledgement that, hey, we are in this ourselves, but it is ourselves. It is not myself. And, highlighting that. Like there's, we few, we happy few, whatever you want to say. Probably we happy few is not the right word, but that we're creating that, or we're helping to reinforce that we're members of an elite group that are responsible for this, or that are enduring this in a very unique and special way.
Absolutely. And I would take it even one step further, not to get in the weeds about it, but, I very frequently, like when I'm on my other podcast or when I'm talking with my patients, I like to counsel them on consumptive dopamine sources and creative dopamine sources. We have transitioned as a society to relying very heavily on consumptive dopamine sources, whether that be food, whether that be substances, whether that be social media, whether that be likes, clicks, whatever, versus creative dopamine sources, writing music, painting, going to the gym, building a family, building a career and a profession, getting out in your community and building that actual social network in real life, that tangible social network that has tangible benefits that is truly incomparable to a social media network or social media social network. And we've built ourselves a reliance on that consumptive source of dopamine to the extent that a lot of us are forgetting how to create. A lot of us are forgetting how to connect. A lot of us are forgetting how to be vulnerable. And I don't mean to make it sound like overly poetic and deep, but it's very, on its face, it's very simplistic. Like, if you can't connect with yourself, i.e. in the form of art, i.e. in the form of music, i.e. in the form of the gym, of bettering yourself in some way, learning a new skill, a new trade, a new whatever, how in the hell are you ever, like, how can you expect to connect to another complex being if you're struggling to connect to yourself? And I think that's one of the challenges is we've gotten to this very, like, very superficial, very vain sense of self and away from a very deep sense of self, a consumptive sense of self versus a creative sense of self. And now we're wondering why on earth we can't connect with each other and why on earth we can't be invested in each other and know each other. And it's because a lot of us have become such superficial, boring ass people. I mean, like, it's hard to get people to work because they don't have a sense of duty and they don't want to work. They don't feel like they belong in the community and the country, and they feel like they're just a cog in a wheel. So then they don't want to work. Society falls apart. And like, it's grandiose, but it's also very simplistic. Like, you have to be able to connect with yourself. Just as, normal human development, you start very egocentric and then you start to recognize, oh, like, when I steal Jimmy's toys, Jimmy cries and Jimmy feels pain. That makes me feel sad. And like, we kind of have regressed in that regard of like, we're not connecting with ourselves. We're not connecting with each other anymore. But I see it in my patients and I see it in my medics. It's like, I'm just a cog in the wheel. Nobody really cares. If I don't show up to work, what does it really matter? And with fire and EMS, it's a little bit more real because if you don't show up to work, then the person who has to show up to work on your behalf. That person, you know them well. Whereas nowadays, like, outside of that realm, if you call into work at Chili's, you probably don't know the person who's going to be working for you, or maybe nobody shows up.
I think we all will sack up and bring ourselves to work, probably at times that we shouldn't. I've worked shifts in the ER with an IV in place, and which a friend of mine is a surgeon. He saw me, like, I would go see a couple patients, then go sit down and chart, hook the IV back up, and charting, and probably should have just taken a sick day. And he took a picture of me doing this, and then put that as the background on all of the computers in the surgery lounge. It said, "This is what we expect of you as surgery residents to this level of commitment." It really, I think it was. I mean, he was needling me about it, but I'm like, wow, yeah, I could think maybe he has a point. That you're right. We know the person. Like, if I say I can't come to work today, then I know the person that I am inconveniencing, if you will, to come and take my place because there are so few of us.
Yep. And that sense of belonging, that sense of duty is inherently tied to that sense of community and that sense of understanding who you put at risk, who you inconvenience, who you're screwing over, or who you're missing out on helping. Are you going to run a little bit faster if you know your neighbor who's 60 years old that you watched her kids and her grandkids, and went to barbecues with? Are you going to run a little faster when she has a cardiac arrest rather than some random person on the street that you don't know? Absolutely. It's inherent. The more connected you are to somebody, the more emotions are involved. The more emotions are involved there's an art to it. You can have an inappropriate emotional response, but emotions are a huge motivator. And I think kids are a prime example of that. Like, I guarantee ambulances drive faster when they know there's a pediatric arrest. I guarantee it. And it's kind of that thing. And it can be a very good and powerful thing if you have that connection, if you have that appropriate emotional response. But the less interconnected we become, and the less we know our neighbors, and the less we know our coworkers, and the less we know our departments, the worse it's going to get.
Well, I think you touched there on some of the indicators of burnout. So when you're not feeling that connection, when you're not feeling that need to get there, like, okay, that's another arrest, going to the call that would have at some point given you an extra kick, extra motivator.
I think all of this is so interconnected, and I feel like I'm using the same words over and over: interconnectedness, community, brotherhood, sense of belonging, duty. But like, if you are connected with your community, if you are invested in your community, you serve with a different sense of purpose. And I think that was very humbly demonstrated and manifested with the duty and honor and war culture that existed during World War I and World War II. It was united in a front, similarly to how everyone felt around 9/11. I was in seventh grade during 9/11, and I still remember where I was standing. I still remember the class I was in. I still remember what my teacher was wearing. Like, it was a moment in time when everybody was truly united. And I think the pandemic was an opportunity for us to be united, and we failed miserably. And it just became very tribal and very, very frustratingly selfish. Very, very frustratingly selfish. And I think there were a lot of good people who did a lot of good work, but I think the sad part is it very frequently was about the individual. It wasn't about the collective. And some of that was manifested on, like, people struggling to find toilet paper, of all things. Like, there were so many opportunities for communities to come together, and they didn't. And I think the first responder community in general did for a long time. And then it kind of got to the point where they were like, this is not what I signed up for. I don't feel like I'm valued in my community, or I feel separated from my community. Some of that, I think, was just organic separation.
You talked about some of the contributing factors to mental health and stress and substance abuse, and you mentioned sleep deprivation. And we work in a 24-hour-a-day specialty and frequently work 24-hour shifts. And a lot of times medics, on the one hand, they are saying, oh, I'm so tired, like I can't even safely drive home from my shift. And then we say, well, okay, maybe that shift needs to be a 12-hour shift then, and we shouldn't be having you working 24 continuous hours. But then there's a strong pushback against that because, well, you're 24 on and 72 off, and you get the time off, and they really are very protective of that 24-hour time. How do we how do we get a good view of how fatigued the medics are? I think we see that unit hour utilization is perhaps not the best measure because you can have 12 continuous hours unit hour utilization during half of your shift and then sleep the other half of your shift and probably doing pretty okay, versus you have 45 minutes off here, an hour and a half off there, et cetera. So overall, the UHU doesn't look that bad, but when you look at actual like protected downtime, it's not really good. And how do we recognize the times that really this does need to be a 12-hour shift? Like the workload is not manageable here. How do we identify that so that we can address it?
Yeah, how do we reconcile the requirements of the job with the natural shortcomings of being an eating, sleeping, breathing human being? It's damn hard. I was very privileged, and I say that dripping with sarcasm, to have the opportunity to do 24-hour call shifts at a level 1 trauma center as a family medicine resident in Northeast Tennessee. We were the code team. In addition to our own patients, it was an open ICU. We ran our own vents. I got excellent training. I was very lucky. I was very privileged in that regard and very lucky in that regard. But I got to experience what it was like to be clinically on for 24 hours at a time. And you're exactly right. Being on clinically for 12 hours is manageable and doable, no problem whatsoever. But you can't guarantee in a 24-hour period when you're on for that entire 24-hour period that you're going to be running, going, and doing for 12 hours and then have 12 hours of downtime. And I can tell you the most soul crushing thing in the world is to be on for 12 hours and then 9 and 10 p.m. hits, and then you get a call every 30 to 45 minutes like clockwork. It is eviscerating because it's just enough opportunity for you to begin to think about relaxing, and then you get amped up. There were studies done that demonstrated that whenever a fire bell went off in a firehouse, that a firefighter's heart rate jumped to 80% maximum. I mean, you can't hear something like that and not be like, "Oh, I'm sure that's healthy." I mean, that's damn near equivalent to doing cocaine. I mean, it's a huge jump in your adrenal glands getting activated, in your pancreas getting activated, in your brain getting activated, in your heart getting activated. Like you can't sustain that. And we have excellent data that demonstrates that night shift workers suffer diabetes, hypertension, metabolic syndrome, obesity, MI, and stroke, and premature death at a rate greater than day shift workers. So we have the data to demonstrate that it's not healthy. I think reconciling the needs of the job with requirements of being a normal human being are very difficult. I know that California experimented with a model, and they're still using it in some cities where they do 24 on, 24 off, 24 on, 24 off, 24 on, 24 off for about 5 days, and then they get 5 days off in a row. And a lot of the fire and EMS folks out there really like that. And I think collectively, what we can all agree on is we like days off. And we don't like days at work, as a general statement. So how do we figure out an opportunity to maximize days away from work and maximize productivity while we're at work? One of the models that I've seen used for emergency positions that I actually find very interesting. I've personally never worked in it, but is a model where you start off your shift in theory when you're the most fresh in the highest acuity areas. After that, you work your way through into things that are a little bit less high acuity, a little less procedurally driven, and are a little bit more mundane. And I think it's kind of a unique situation in that if you can get creative enough to make it work, and it kind of, I would imagine, would require some degree of like status system management, knowing where your high priority calls are going to be, and getting folks that are fresh within their shift in those areas, in those high volume areas. And as they become less fresh in their shift either to areas of the city or areas of the grid that are less busy, or quite simply have a carryover where you have 2 shifts on, which I recognize is going to require more money and more staffing, split over 12 hours, where you have 12 hours of fresh crew. They're doing the active, high acuity, running all the call stuff. And then you have another crew that's back up in the event that there's any high acuity calls, and or they're doing the mundane stuff, taking care of the firehouse, taking care of the ambulances, doing all of the secretarial work, quote unquote, that needs to be done in the day as well. And then when they're not doing those things, your shift that's not as fresh has an opportunity to sleep that's relatively protected. I think there will never be a perfect system where you have true protected time that's dedicated to just sleep. But I think having that backup of where you have that fresh crew for 12 hours and then you have the not fresh crew for 12 hours and they just overlap back and forth. So you have more opportunity to have more protection in theory, so you can actually get some sleep.
So when you protect that time, is there recommended length? Like you talked about how you call every 30 minutes, you're just thinking about relaxing, and then you get a call. So obviously that's not the answer. But what does that break look like? Is that 2 hours? Is that 4 hours? I mean, ideally, of course, 8 hours. But I don't think that, as you said, that's not very practical. But what does that true break look like?
I think a doable and feasible and equitable system would look at 4 hours out of the night shift and 4 hours out of the day shift that are the least busy. And those 4 hours for both least busy aspects of the shifts are your protected time for sleep. Obviously, there's going to be some variability, but if you have two ambulance services or 2 ambulance shifts covering on that particular period, your shift that is in theory in their downtime can be the backup. and it just provides an extra layer of protection. Would it mean that those 4 hours were truly always universally protected? Of course not. But I think that's a little bit more reasonable and equitable. And I think 4 hours, while it is not ideal, I think 4 hours of sleep consistently for folks that are used to not getting consistent sleep would probably sound pretty good.
For the shorter shift lengths, like the 12 hours, I mean, I know that from emergency department shifts, so running constantly for 12 hours where you don't even have a chance to pee is challenging. Is there an ideal rest break in there? Maybe not for sleep necessarily, but decompression time.
Absolutely. I mean, if I could wave a magic wand, and I think, I threw the economics of it out the window, I think 9-hour shifts circulating back and back, so three shifts a day would be the best, because I think 9 hours is sustainable. You can absolutely get just crushed for 9 hours, and that sucks. But at least if you're only getting crushed for 9 hours, you still have 8 hours of your day for sleep, and then you still have another 8, 9, 17, still another 7 hours of your day to be productive with outside of work, outside of sleep. So, like, God forbid, time for yourself, God forbid, time for your family. And I think that would be the perfect situation. I went from working in general 12s with occasional 24s in family medicine to only 12s in emergency medicine residency to now working 9s, and I love 9s. If I work 5s, I'd probably love 5s, but I do. I think 9 is kind of the realistic balance of, like, even if I have an awful shift where I see 45 patients in 9 hours, which I've had, it's still thankfully just 9 hours, and there's an end in sight.
Yeah, I think that'll vary by job. Obviously, I've had those same shifts, and those are a kick in the face. 45 patients in 9 hours. There, I think with EMS, a little bit of different, little bit of different pace. You're one patient at a time. You've got this defined block that they're with you, and so. But still, maybe 16 every once in a while instead of 24 is better. I found that working 24-hour shifts in small critical access places, that when you come in for 12 hours, you come in for 16 hours, like, that's just a day. But you eat breakfast, you go there, you eat a meal at some point, you come home, you eat, and then you get to bed. Whereas if you're there for 24 hours, you have to plan for 3 meals there, you plan for sleep. It's like a whole different level of preparation, I think. And
it's hard to get comfortable in a space that's not home. And I think that's one of the reasons why firehouses traditionally have had this very warm, welcoming, home-like culture, is to try and recreate that, because originally when firehouses started, that's where people lived. But I think it's hard, even when you're going out of your way to create that home-like culture. It's still not home. It's still not as comfortable as your own bed. It's still not as quiet as your own home at night. So I think it's a challenge. But I do think having the occasional shift that's a little bit shorter, I think, would just do well for your psyche, if nothing else, of knowing, like, okay, this is a shorter shift.
Yeah, our nurses will sometimes pick up the smaller overtime blocks, like a 6-hour shift, and they call it a princess shift. They're always happy on those shifts. Like, yeah, it's a little princess shift. It's okay. I mean, and they're in triage and just getting their butts handed to them, and just, people coming in, and they're still really happy. And for 12 hours, different story. It just feels different. So I think with EMS too, it's hey, I know this shift is going to end at this time, and so even if I'm getting crushed, then I'll be doing all right. Now, we mentioned substance abuse, and obviously all of the negative effects that has on your mental health, your work life, your home life, and we've unfortunately seen some people succumb to it to a level where they could not function in this career anymore. And I think that there's so much tied up in drug testing and so forth that if you pop hot on your drug test, like, you're really good chance of losing your job with that. And so obviously folks really don't want to highlight themselves if they are struggling with alcohol or misusing prescription drugs or whichever. is there a better way? Is there a better way that we can identify folks that are having those issues and that we can get them lined up to help where they're not as incentivized to hide it as they are currently?
Part of the challenge is that the culture around substance abuse and the conversation around substance abuse has to change. We live in a society that exists in a very bizarre and very confusing duality. Absolutely, and full disclosure, I mean, I enjoy bourbon. I enjoy red wine. Like, I have no problem with that whatsoever. This is not meant to come from a place of judgment, but rather just some thought-provoking questions and statements to get people thinking. The average person doesn't know what binge drinking is as far as like how many drinks it is. And I think the average person would be quite shocked that a male having more than 5 drinks in one sitting is considered binge drinking. And a woman having more than 3 drinks in a single sitting is considered binge drinking. I know plenty of people as an addiction medicine physician who go out and have more than 3, 4, 5 drinks in a single sitting that are not alcoholics. So it's a very nuanced conversation, but at the same time, if you're having more than 3, 4, 5 drinks in a single sitting on regular occasions, and you can't simply from one week to the next have the decision of like, all right, I'm going to go 3 or 4 weeks without drinking, then I'd be a little concerned. I think we have a society that very much has normalized substance use in the form of alcohol and in a large degree in the form of marijuana, and for historically a long time tobacco use, which definitely doesn't get as much attention as it deserves because a lot of people are like, tobacco, nicotine, big deal. Marijuana, big deal. And there's risks to all of them. Alcohol, undeniably, 100% causes the most detrimental effects from an economic standpoint and from a medical standpoint of any substance in the United States of America. The last statistic I saw was actually 2016 or 2017. So that was an old statistic. It was like $60 billion a year. I have no doubt in my mind, especially with COVID, that probably doubled. But non-alcoholic fatty liver disease is actually supplanting alcoholic liver disease as the leading cause of cirrhosis in the United States. But alcohol definitely plays its part. And alcohol 100% has been normalized and accepted by society. Again, this is not coming from a judgmental place. I enjoy bourbon. I enjoy red wine. I absolutely understand. But when I talk with my general population addiction medicine patients, I always try to kind of preface it of like, on our off period, we were talking about consumptive dopamine sources versus creative dopamine sources. If you look at dopamine as a currency, whenever you have a drink, you're gaining some currency. It's a cheap, easy way to feel good, put another way. A creative dopamine source that is a less cheap, a little bit more time consumptive, a little bit more a requirement of a little bit more vulnerability and connection and emotional availability. Forming a relationship with your dog, with your kids, with your husband, with your wife, with writing music. All of these things also provide feel good, but they're not as cheap, they're not as readily available, and it's not as quick to consume. And so when we have a society that as a group has collectively moved towards consumptive dopamine sources rather than towards creative dopamine sources, we're kind of creating this gigantic problem in the sense that we're really learning how to be consumptive for our feel-good hormone rather than creative for our feel-good hormone. Dopamine evolutionarily is part of the thing that binds us as a society. It's one of the things that helps you form a family unit. It's one of the things that helps you feel at home, quite literally. You have dopamine when you walk in the front door of your house. Literally seeing your comfortable, familiar space gives you dopamine. So it's a very important chemical, but it can be taken advantage of and kind of adulterated by substances. And I think that's the important way to look at it. But I think specifically with the first responder population, one of the challenges is that there is a problem of illicit substances, but the problem of legal substances is dramatically higher. There is not good, reliable data that I'm familiar with, at least, that talks about how common binge drinking is amongst fire, EMS, and PD. But I would wager that it's probably approaching 40 to 50%, if not more. Departmental culture is going to affect a lot of that. I am not saying that there is anything wrong with going to a Sunday barbecue with the fire chief and having a couple beers. I am not saying there's anything wrong with that, unless you're a functional alcoholic and you don't need to be drinking. That's a very different conversation. But I think that's the challenge of finding balance, is that we have to be comfortable kind of, echoing back to what we were talking about before earlier in the podcast, as far as creating that community, creating that brotherhood, that sisterhood, that sense of belonging. We have to feel comfortable in investing in and engaging in those creative dopamine sources, quote unquote, just as comfortable as we are, or excuse me, much more comfortable than we are investing in those consumptive dopamine sources. If you feel like it is easier for you to go home by yourself and drink, rather than you feel like it is easier than for you to open up to your partner about a bad outcome that you both just experienced, you absolutely should be asking questions about your relationship with alcohol. And it sounds less serious on its face because we've created a culture of acceptance with regards to alcohol, and to a degree with nicotine, and to a degree with marijuana. But all of those are substances. All of those are quote unquote cheap sources of dopamine, or consumptive sources of dopamine. Sometimes I'll refer to them as non-wholesome sources of dopamine. But when you have those wholesome sources of dopamine in your department, with your family, walking your dog down the street, taking yourself to the gym, writing music, listening to music, painting, throwing the football with your kid, whatever it is, those are the kinds of things that don't create cirrhosis, that don't create COPD, that don't create obesity, that don't create metabolic syndrome and hypertension. And there's a reason for that. Like, if anything, those sources of dopamine are protective against those things. And kind of tying it all in together, we briefly talked about the ACE scores with Vincent Folletti and the adverse childhood experience, and risk stratifying those particular events, and demonstrating that bad outcomes, that bad events as a child are associated with bad outcomes as an adult. We have to do a better job of identifying those things that our folks are getting exposed to, and that we're getting exposed to, and provide resources in a way that's proactive rather than reactive, so that we can prevent people from engaging in substance abuse specifically being the quintessential word specifically. Because again, I don't think there's anything wrong for people who don't struggle with alcoholism to have a beer or two. But if you, as a fire, EMS, police officer, experience a bad call, have a bad outcome, have a stressful, violent patient or violent perp or violent whoever, and you want to go home and have a drink rather than open up to your wife, your husband, your chief, your partner about it, that's exactly when the conversation should start of what is my relationship with this substance. And I use alcohol just because that's probably the most common one, but whether it's marijuana, whether it's even a cigarette, if that's where you're at with your relationship to a substance, you should reevaluate your relationship with the substance. And that's, I think, the best time to intervene, because if you can have that awareness of like, why do I want this drink more than I want to go sit in a church and talk to a pastor, or go throw a football with my kid, or go to the gym, or talk to my wife, or talk to my husband, or talk to my chief? Why is it that I'm more drawn to this substance? Is it because it works better? That's when you really should worry. And that's when I think it crosses over into true addiction, is when you can, genuinely vocalize to yourself, because it's hard to say out loud. Addiction is very subtle. It's very convincing, and it's very good at making you believe that you don't have a problem. But if you can say to yourself and to your mind, like, maybe I do like this more than opening up to my family or opening up to my department, that's really when you should worry.
It's funny, when I work an evening shift and I come home and I go to bed, my wife wakes up early in the morning and comes into the kitchen and sees a bottle of whiskey and a glass that's sitting there. She knows, like, oh, had a Bad call, huh? Or bad shift. At 2 a.m., 3 a.m., I don't think I can wake up my daughter and say, hey, honey, let's go through the football. Yes, she would not, neither one of them would appreciate that very much. But what are some of those quick sources? You talked about a quick and easy source of dopamine and how substances are quick, easy sources of dopamine. And, in that setting, it's more convenient. What else is there that what can I do when I really just want to unwind from that call, that shift, et cetera, and I don't have the time to plan it, or I'm a weird hour of the day. What are some of those things that I could do to help to get that same effect and but in a healthy way?
Absolutely. So I think there's a multi-pronged thing. I like to challenge my patients, and I would like to healthily challenge your notion of what's a quick, easy thing I can do. I think there are quick, easy things that are healthy and that are wholesome, but I would argue even a step further, even when you're exhausted and you're tired, you just finished a 12-hour shift or a 24-hour shift, pouring your heart, soul, and energy into taking care of your patients, into protecting your community, into doing the right thing. Can you find another 10 or 15 minutes to pour your heart and soul into yourself? Sometimes the answer is no. That's fair. I've been there. I've literally come home so tired from a shift, I have fallen asleep on my living room floor. I entirely understand that. But I think we have to change the cultural perception with ourselves with regards to convenience. Ultimately, convenient often isn't always best. Sometimes it's literally all you got. But a lot of the times it really is worth the extra effort to find a little bit more energy to put that time in yourself. And whether that's going for a walk around your neighborhood, whether that's going for a jog, if you have the energy, to the gym, if you have the energy, it can be as simple as listening to music that helps you reflect. It can be as simple as writing down what you're struggling with and then going to sleep so that you can come back and unpack it when you're well slept. It can be as simple, like I'm a dog guy. I've got 2 dogs. It can be as simple as sitting there and loving on your dog. And that's the nice thing about dogs is they don't care what time of day it is. They'll wake up and they'll come play fetch with you anytime. Sometimes begrudgingly, but they'll always get up. And I think that's exactly the thing, is that the sources that work the best, the things that do the best to refill your cup are the things that don't tend to be super convenient. In my opinion, and again, I'm a dog guy, I think the most convenient is a pet. But you still have all the added inconvenience of feeding them, cleaning up after them, taking care of them. So again, I think the best sources are associated with inconvenience. And I think the purpose of that inconvenience is to make us recognize the value of time. And it sounds, kind of like poetic and philosophical, but I think it's the truth. We spend so much time pouring our heart and soul in our lives, into our careers. We should spend some time pouring our heart and soul into ourselves, into our personal development, whether it be as grandiose as painting or picking up a new hobby or learning a new language or picking up reading a new book, or whether it be as simple as listening to our favorite song and thinking about, our day and reflecting over the good and the bad, writing down our thoughts, or throwing a football around with our child or talking with our wife or our husband, or anything else that really grounds us. And I think the flip side is that I do think, and a lot of my addiction colleagues may push back at this, but I do think there's a role and a place for substances. I don't think there's necessarily anything wrong with having a beer or two, but I think the important aspect is what you do with it. Historically, we can think about a lot of artists who are in the extreme of creative dopamine, not like your average person, but a lot of artists like to dabble in substances and then go and create. So I think there's a sweet spot. I think there's a potential ability to leverage the fluidity that can come from substances, from alcohol, from even nicotine. Nicotine is a stimulant, and nicotine in the short term does increase cognitive output. even marijuana to a degree. I think there is a role for it to facilitate the creative process. The problem is when it completely replaces the creative process, that you have a problem. Um, I mean, I know lots of people who go home with their wife or their husband, and they love to have a bottle of wine between the two of them and just like therapeutically vent about their day. There's nothing wrong with that. I think the indispensable part of that is that it's associated with a creative process. And sometimes that creative process is building a relationship or strengthening a relationship that already exists. But you should also comfortably be able to do it without that substance. So I definitely appreciate you having me, Dr. Pickett. It's always a pleasure to work with you. I think you and I share a lot of things in common as far as our attitude and our perception towards just being able to get things done. I know we both work and enjoy working with the pre-hospital folks. And I definitely look forward to doing this again with you in the future. I think if there was anything that I wanted to leave people with, as far as like pearls and tidbits, mental health and substance abuse avoidance are things that should absolutely be thought of long before they're a problem. To anybody that's struggling acutely, definitely reach out and ask for help. I know that specifically gets said a lot, reach out and ask for help, but really take a second to invest and put some time into yourself and respect that everybody needs help, myself included. There is not a day that goes by that I'm able to do the things that I do purely and solely because of myself. I am facilitated and I am enabled by the support system that I have, and everybody is. And I encourage you to take advantage of that, because that's what that support system is there for when you need it. But when you find yourself on a good day, on a normal day, put some thought into what your mental health and well-being means to you. Put some thought into what your defense mechanisms against burnout are. Whether or not that is your faith, whether or not that's your community, your pets, your family, your department, your administration. Put some thoughts into that and kind of have a brainstorm of how you would approach those shitty days. Because when we drill all the time that perfect practice makes perfect, and planning prevents piss poor performance, and we drill so that we perform well under pressure, but we don't really think a lot about mental health and drilling for mental health. But I think that's a good thing to focus on. I also think a quintessential thing that I try to work and teach my patients is that you should always be evaluating what the role of a consumptive source of dopamine is in your life, whether it's social media, Instagram, Facebook, to turn off and just kind of be mindless, whether it's TV to just turn off and be mindless, whether it's substances, anything that doesn't push you to develop yourself a little bit. You should always be reevaluating your relationships with those, because as everybody that is listening to this, you have experienced success in your life. You know what it's like to do CPR. You know what it's like to be a firefighter, to be thanked by someone for saving their child, their cat, their dog, for protecting their community, for doing the right thing, for being there when no one else was. Every single person can relate to the fact that when you put in work and you succeed at something, it's infinitely better than a great drink. And I think it's easy to forget that sometimes. So when you have the ability to really reevaluate your relationship with substances, definitely don't be afraid to ask yourself those questions of, have I forgotten what it's like to go paint, to write music, to go to a concert, to go to the gym, to throw the football with, or color with my kid, like whatever it is that is a creative process that develops you or develops a relationship that you have a little bit better. You should always be reevaluating those things. And I think that's a very important defense mechanism against inappropriate substance use and abuse. And last but not least, I think the biggest thing is recognize what you do for your community, recognize what you do for your partners in your department, and recognize that we are all in this together. And I don't mean that in a campy way, but quite literally, like our department is contingent upon our department being close and being close-knit and knowing each other and knowing when we're having a bad day or a good day, and knowing that we can count on each other when we are having a bad day to help and to offer a hand and to be there to listen when we need it. There's not a person that probably listens to this podcast that doesn't know someone who's either contemplated suicide or done it. And a lot of that started from the fact that unfortunately there were folks that knew and loved that person, but for whatever reason, that person didn't feel comfortable opening up about that. And that's a terrible feeling. And yet it continues to happen every single day. So I think we have to be aware of our place in our department and our place in our support system and our place in the support systems of people around us. And really trust in that camaraderie and that community that we've built.
As leaders, as chiefs, as medical directors, as supervisors, that what can we do to help to foster that open environment, that friendly environment for help and for healing and for treatment?
There's an art to it, but I think the biggest thing is you got to be approachable and not punitive. You have to create the environment that allows the people that are working for you or working with you or working underneath you or whatever the dynamic is. You have to foster the environment that says, when you're having a bad day, you can come to me. You have to foster the environment that says, if you're struggling with something, you can come to me. It really does fall on your shoulders to bring yourself to the person that has need, not expect the person that has need to come to you. And that comes from being aware of your department. It comes from knowing your department, and it comes from creating a culture that accepts that. And honestly, that doesn't simply accept that, but expects it, that that's the norm. And quite honestly, I think if you can reach the point as a supervisor, as a chief, as an administrator, as a medical director, that when you're having a bad day, you open up about it, I think that sends waves as far as awareness of what your leadership style is.
So I really appreciate having you on here and the very unique perspective that you have and experience and knowledge that you bring to EMS, which straight up, I don't know of anybody else that has that kind of knowledge and experience in this specialty. So hearing you talk about it and bring those ideas here is just fantastic. And I really want to thank you for spending the time with me today to talk and get this out there.
Absolutely. I am happy to help anytime. And it doesn't have to be substance abuse and mental health oriented. I'm happy to help in any way. But it is, I think, and we didn't even touch on it, but I think once we can identify risk factors and we can start risk stratifying people, then we can figure out what the economic impact is from decreasing burnout and decreasing turnover in a successful manner. And I think there's an opportunity to make it easily sellable and therefore easily implementable on a large scale and God forbid, save a couple first responder lives while we're at it.